Welcome to Roadmap to Residency. Hello everyone, I am Aviras. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys on your journey to a 250. So, biopsy of this patient's thyroid is most likely to show which of the following findings. So the question is asking us about the pathology of this patient's thyroid. So we have a 51-year-old woman comes to the office due to progressively worsening fatigue, weight gain, and constipation for the past 6 months. The patient has had difficulty performing daily activities due to her fatigue. She has no significant medical history and takes no medications. The patient has no drug allergies and does not use tobacco, alcohol, or illicit drugs. Blood pressure is 110 upon 80 millimeter of mercury and pulse is 55 per minute. Physical examination shows a mild diffuse enlargement of the thyroid gland. Cardiopulmonary and abdominal examinations are normal. So here we can see that we have a 51-year-old patient, a woman who have decreased metabolic responses, who have fatigue, who have weight gain, and who have constipation. And we can also see that the patient has decreased blood pressure and the patient has bradycardia. So most commonly, maybe this patient is suffering from Hashimoto's thyroiditis because the patient is also having a mild diffuse enlargement of the thyroid gland. So what are the options we have? Branching papillae with cells containing impurity appearing nuclei, dense fibrous tissue extending beyond the thyroid capsule, follicular hyperplasia with tall cells projecting into the follicular lumen, intense lymphoplasmacytic infiltrate with active germinal centers, widespread inflammatory infiltrates, giant cells, and disrupted follicles. Pause the video and think what is the answer. So this patient has chronic lymphocytic thyroiditis or Hashimoto's thyroiditis, presenting with hypothyroidism features and a diffuse goiter. Now, this autoimmune disease occurs predominantly in women and has a peak incidence at age 45 to 65 and is most common cause of hypothyroidism in iodine sufficient regions such as United States. Now, in all forms of primary hypothyroidism, lab studies show low serum thyroxine levels and elevated TSH and antithyroid peroxidase antibody level are usually elevated in Hashimoto's thyroiditis, but they are not specific to the disease, as they are also seen in all the other autoimmune thyroid disorders like postpartum thyroiditis and Graves' disease. If the diagnosis is uncertain, then we just go for the thyroid nodularity, and a biopsy can be performed to rule out malignancy. The characteristic findings of Hashimoto's thyroiditis include lymphocytic infiltrate with formation of germinal centers in the biopsy. The residual follicles are often surrounded by Hurdle cells. Now we will see a picture of Hurdle cells, but these are the large cells with granular eosinophilic cytoplasm, which represents the follicular epithelial cells that have undergone metaplastic change in response to inflammation. So the thyroid follicular cells under response of chronic inflammation, as this is a chronic disease, will undergo metaplastic change, and the cells will become larger and they have a granular and eosinophilic cytoplasm, and these cells will be called as Hurdle cells. So these are the Hurdle cells. Okay, you can see the abundant granular eosinophilic cytoplasm. Okay, and these are the big round nucleus. Now, this is due to the metaplastic change in the follicular cells. This is the biopsy image of the Hashimoto thyroiditis. We can see the germinal center here, which is surrounded by the lymphocytic infiltrate, and these are the thyroid follicles. Let's talk in a brief about different sorts of thyroiditis. So first of all, we have chronic autoimmune thyroiditis, or also called as Hashimoto thyroiditis. Now these are the predominant, these have the predominant hypothyroid features, and these have a diffuse goiter, as our patient had. But this patient also have positive TPO, but it is not specific. Why? Because it is also present in, you can see here, in painless or silent thyroiditis. So the TPO is present, but the radioactive iodine uptake will be variable in the case of chronic autoimmune thyroiditis. The short diagnostic method is biopsy. Now the second one is silent thyroiditis or painless thyroiditis. Now it is a variant of chronic autoimmune, and it has a mild brief hyperthyroid phase, and there will be small non-tender goiter, and it will spontaneously recover. Okay, that's why it is called as silent. It will have a brief phase of hypothyroidism, and then it will again spontaneously recover. Talking about subacute or decurrent thyroiditis, these are generally a post-viral infection mediated thyroiditis. The question will mention about the patient had sore throat or the patient had some other viral infections. After that, the patient started having these hyperthyroidism symptoms. Then these are the subacute thyroiditis. These are painful and these are tender. And there is elevated ESR and CRP in case of subacute thyroiditis. Now let's talk about congenital hypothyroidism. Now, it is usually asymptomatic at birth, and it can cause delayed meconium passage sometimes, but it is usually asymptomatic at birth. Now, uh, congenital hypothyroidism is because when the maternal thyroxine or the maternal high thyroid levels, they cross the placenta and they actually cause suppression of the thyroid levels, suppression of the thyroid gland in the neonate. Then that will cause uh, now in the beginning there is the maternal thyroid hormone, right, which is acting in the child's body, in the infant's body, in the neonate's body, and it is also decreasing the flow from the thyroid gland, the thyroid production from the thyroid gland. But since the maternal thyroxine are present there, the patient will not have symptoms. But as this thyroid hormone weighs, or as this thyroxine effect goes away in weeks to months, then the child will present with congenital hypothyroidism symptoms or hypothyroidism symptoms, which will include lethargy, poor feeding, enlarged fontanelle, protruding tongue, puffy face, umbilical hernia, constipation, prolonged jaundice, or dry skin. Diagnosis is increased TSS and decreased free thyroxine level as any hypothyroidism disease, and the patient should go under newborn screening. The treatment is levothyroxine. The prognosis is untreated disease is associated with neurocognitive dysfunction, but there are no deficits if the treatment is started in the neonatal period. If we catch the disease early, then there are no such complications. Now, let's talk about some of the thyroid function tests, okay? How we can actually determine the diagnosis of the thyroid disorders with the thyroid function test. So we just go for the TSS testing. So if the TSS is decreased and if the free T4 is also decreased, then this is primarily due to the TSS deficiency. Okay, this is the central hypothyroidism. The disease is not in the gland. The disease is in the center, right, in the pituitary. Now, if the TSS is decreased and free T4 is normal, then it is due to the subclinical hyperthyroidism. It is the T3 toxicosis. Now, if the TSS is decreased and the T4 is elevated, now the defect is in the gland itself. So this is the primary hyperthyroidism. Now, if the TSS testing is normal, no further testing is required. When the TSS is elevated, right? When the TSS is elevated, then we just go for the again free T4. If the TSS is elevated and the T4 is also elevated, then that is the TSS secreting tumor. Now, if the TSH is elevated and T4 is low, then this is the primary hypothyroidism. So what is the subclinical hypothyroidism? So if the person has normal T4, free T4, and if the person has normal T3, but he or she has high TSH in the presence of positive antithyroid antibodies, then that is called as the subclinical hypothyroidism. Now, it is always discussion about what to treat subclinical hypothyroidism or not. So we need to look for the benefits and the drawbacks of the treatment. So if there are if there is improvement in the mild symptoms, or there is no weight loss, there is improved lipid profile, if there is prevention of overt hypothyroidism when we start the treatment, then yeah, we need to actually continue the treatment. But there are some of the drawbacks, like improved symptoms, lipids unusual with TSS between the 5 to 10, if there is potential of over treatment, if there is expense of lifelong medication because of the treatment, then there is actually some of the discussion whether to continue the treatment or not. So here we have, when there is the elevated TSH, we go for the confirmation by free T4, TPO antibodies and lipid level. If the TSH is less than 10 and anti-TPO is positive, we need to consider the T4 treatment. If the TPO is negative, but there are some symptoms, okay, then again we need to consider the T4 treatment. If the TPO is negative, but there are some symptoms, for example, the patient is elderly, the patient has goiter, then we need to close the follow. Then we need to uh, plan the follow-up. We need to just look for some days, and we need to again call the patient, and then we need to start the treatment. Or you can just start the treatment beforehand, starting from the day one. It completely depends on the choice of the physician, the treating physician. That is all for this video. Thank you for watching. We will again back in the next one with again a super duper concept. Thank you all.